go to Dr. Chim, who's going to tell us about prospects for immunotherapy in myeloma. And I did want to just alert you to the fact that there will be a small change in the program. The amyloidosis talk will be given after lunch so that everybody can have lunch in a timely fashion. So there's extra pressure on Dr. Chim to stay on time.
Oh, thank you very much, Dr. Olowski. It's so much of a relief. So, anyway, I'm James Chim from Department of Medicine, Queen Mary Hospital, University of Hong Kong. So I'm going to actually to share with you some of the recent data in immunotherapy in myeloma. So, I think cancer immunotherapy actually has to start with this cancer immunity cycle. Actually starts with, first of all, release of the tumor antigens from the tumor, and then it will be taken up by these antigen-presenting cells inside the tumor, which will traffic to the regional lymph node, and they will process and present these antigens to the cancer-specific T cells in the lymph node and activate them. And this activated T cell will traffic back to the tumor site, infiltrate the tumor, and then recognize the tumor and kill the tumor. And because of time, actually I have to focus on the more salient data on immunotherapy in myeloma. So first of all, I will start with cancer vaccine. So basically, cancer vaccine is to induce a cancer-specific immunity in a patient without that immunity. So there are actually a series of recent clinical trials from clinical data from the Dana-Farber group they use this fusion dendritic cell and myeloma plasma cell fusion vaccine in myeloma. So basically, the patients dendritic cell can be derived from the peripheral blood mononuclear cell by culture with interference interleukin-4 and also GM-CSF, and then mature by TNF-alpha. And in that stage, actually the DC can be fused to the myeloma plasma cell in the presence of polyethylene glycol. And because of that, these fusion cells will express both markers of the myeloma cells, including CD138, and also markers from the APC, that is CD86. And in this fusion cell, it is shown that they markedly upregulate expression of co-stimulatory molecules, including CD80 and CD86. And these cells express high levels of interleukin-12, which is very important for Th1 polarization. And these cells express a chemokine receptor CCR7, which is important in directing this dendritic cell to the regional lymph node for priming and activation of the myeloma-specific T cells. Moreover, they've been shown to stimulate T cell lysis of myeloma targets. And therefore, a phase 1 study of this fusion vaccine has been performed in advanced myeloma in 18 patients using 1 to 4 million fusion cells, and in patients with advanced myeloma. And first of all, there is no dose-limiting toxicity, and this is associated with an expansion of myeloma-specific CD4 and CD8 T cells, and it is also associated with a disease stabilization of up to 14 months. And because of that, this fusion vaccine has been also been employed in another phase 2 clinical trial, this time in transplant-eligible myeloma patients at the time after bone marrow transplantation. So this is actually the schedule of the study. Basically, all these patients are transplant-eligible patients. They went through induction, and they went on to receive stem cell mobilization and the autologous stem cell transplantation. And this V1 and V2, V3 actually stands for the time of the 3 times of vaccination. And afterwards, they will have a monthly they will have this monthly monitoring of the immune response as illustrated at month 1, 2, 3, 4, 5, and 6. And the median time to vaccination is 1.3 months after transplant. And the mean dose of this fusion disease is 3 million cells. And this is associated with a tenfold increase in this myeloma-specific CD4 and CD8 T cells, as shown here. So this is CD4 and this is CD8 T cells after the vaccination. And moreover, by tetramer analysis, there is also an expansion and 15-fold increase in this MUC1 reactive CD8 T cells. And importantly, there is no concomitant upregulation of regulatory T cells. As you know, the Treg cells are important in down-modulating the immune response against cancer. And moreover, clinically, about almost half of the patients achieve a complete remission after this protocol. And VGPR is achieved in 78% of the patients. Importantly, 1/3 of this CR actually occur 100 days after vaccination. And in view of the absence of lenalidomide maintenance in this cohort of patients, this delayed CR is very much compatible with a vaccine-induced immune response. So in conclusion, this fusion DC myeloma plasma cell vaccine is well tolerated, is effective post-transplant, it generated effective myeloma-specific cellular immune response without upregulation of regulatory T cells, and is translated into clinical response. And I would like to go into, I think this has been alluded to a few times about this adaptive T cell therapy with engineered T cells with a chimera antigen receptor. So this is, in short, is CAR T cells. So CAR T cells is actually an adaptive T cell therapy is at the stage of this step 6. So BCMA, B-cell maturation antigen, has been explored as a potential target for generation of CAR T cells in myeloma. So BCMA stands for B-cell maturation antigen. So it is shown that during B-cell ontogeny, so BCMA is only expressed in plasma cells. The BCMA is actually a TNF receptor family member, and its ligands include BAF and APRIL. And upon binding of the ligand to the receptor, it will generate survival signal to the myeloma plasma cell. So this is basically to show that BCMA expression is restricted to plasma cells, but not CD34 positive marrow cells. So for example, in these multiple cell lines, so this BCMA is only expressed in myeloma plasma cells, but not in other cells, okay? Importantly, it is not expressed in CD34 positive bone marrow cells. And this is actually a real-time quantitative P-cell to show the same magic, basically as BCMA is only expressed in plasma cells, but not in any other cells, especially not in CD34 positive marrow cells. And this is an immunohistochemistry to show you that BCMA is expressed strongly in these myeloma plasma cells. So this is a functional assay to show that anti-BCMA expressing CAR T cells can be stimulated to secrete gamma interferon in the presence of these BCMA expressing targets. But for example, they have a high production of gamma interferon when they co-culture with this BCMA expressing target, but not in the presence of BCMA negative targets. And moreover, the granulation of these CAR T cells is actually only occurs when they co-culture with BCMA expressing targets, but not in cells that is not expressing BCMA. And therefore, the activation and degranulation of these anti-BCMA CAR T cells is actually BCMA specific. And what about in primary bone marrow samples? So this is actually a picture belonging to the experiment when this patient's CAR T cells, BCMA expressing CAR T cells is co-culture with the patient's BCMA expressing myeloma. This is autologous myeloma plasma cells expressing BCMA. And that will induce actually BCMA specific stimulation to produce gamma interferon in these BCMA expressing CAR T cells. Moreover, they will also induce cytotoxicity in BCMA expressing targets. Despite all these very promising in vitro data, the clinical trial is still pending. So now I would like to go into the immune checkpoint inhibitor. So what are immune checkpoints? So immune checkpoints actually are array limiting steps in the generation of tumor-specific T cells. They are instituted by an array of inhibitory pathways based on ligand receptor interaction. And these immune checkpoints are very important in maintaining self-tolerance and important in down-modulating immune response in the sites of inflammation to avoid collateral damage. And therefore, a blockade of these immune checkpoints may potentially unleash the full potential of anti-tumor T cell immunity. And the sites of immune checkpoints, first of all, exist in the lymph node where priming and activation of cancer-specific T cells occur. And secondly, it occurs in tumor sites where effective T cells like cytotoxic T lymphocyte execute tumor-specific cytotoxicity. So, as alluded to, so this immune checkpoints occurs and the lymph node where priming and activation of these cancer-specific T cells occur, and they can be blocked here by anti-CTLA-4 antibodies. Or else, actually, another immune checkpoint occurs at the tumor sites of cell killing, and they can be blocked by this anti-PD-1 and anti-PD-L1 antibodies. So what is actually the status of PD-L1 expression in myeloma? So PD-L1 is found to be expressed in myeloma plasma cells, but not in normal plasma cells. And PD-L1 expression in myeloma can be induced by gamma interferon, And bone marrow stromal cells can induce PD-L1 expression in myeloma plasma cells. Very important, myeloma plasma cells overexpressing PD-L1 inhibit CDL generation, cytotoxic T lymphocyte generation. So what about, this is the ligand, so what about the receptor? So receptor is present on T cells. So what is the status of this PD-1 receptor expression in myeloma T cells? So it's found that the PD-1 is actually upregulated in myeloma T cells compared to healthy T cells. And therefore, there's a clinical trial. There is a preliminary report of a clinical trial of using anti-PD-1 in transplant-eligible myeloma patients after autologous stem cell transplantation. So this is a study done in 27 patients. So all these patients receive 3 doses of anti-PD-1 antibody 6 weekly apart, 1 to 3 months after autologous stem cell transplantation. So the important message from this study is that the side effect profile is really, really well tolerated. So majority, 90% of the side effect is just grade 1, 2, and there is only 1 case of grade 3 diarrhea. And moreover, in 4 patients, 4 of these 27 patients who have completed 6-month follow-up, immune response can be assessed. So in these 4 patients, at 1 month after the first dose of anti-PD-1 and antibody infusion, it is found that there is a marked expansion of myeloma-specific T cells, including CD4 and CD8 T cells. Moreover, there is a 9-fold increase in MUC1 reactive CD8 T cells in HLA-A2 myeloma patients. Importantly, this cancer-specific, myeloma-specific immune response, cellular immune response, is persistent 6 months after completion of anti-PD-1 antibody therapy. Moreover, as this PD-1, PD-L1 axis may dampen cellular immune response to fusion vaccine, hence an in vitro study has been performed in a way to study the effect of PD-1 blockade on myeloma-specific T cell immune response to this DC in the presence of this fusion DC myeloma vaccine. So basically, these are patients whose patients myeloma, myeloma T cells. So these are T cells from myeloma patients, and these T cells are actually co-cultured with this fusion cells. Okay, myeloma DC fusion cells in the presence or absence of this anti-PD-1 antibody. So basically, the message is that in the presence of anti-PD-1 antibody, it enhances Th1 polarization in a way that, as evidenced by the upregulation of gamma interferon in these T cells and also downregulation of interleukin 10. So interleukin 10 is actually a marker of a Th2 differentiation, and gamma interferon is a marker of Th1 differentiation. And moreover, there is concomitant downregulation of the generation of regulatory T cells. And so addition of this anti-PD-1 antibody in the presence of DC vaccines potentially enhance Th1 polarization, they downregulate generation of T regulatory T cells, and enhance myeloma-specific CDL cytotoxicity. Despite all this promising in vitro data, the clinical trial is still ongoing, and there is as yet no clinical data from the trial yet. So thank you very much for your kind attention.
I'd like to thank Dr. Orlowski and Dr. Moody for chairing this session. Unfortunately, we're so far behind that we'll have to hold the questions. I'm sure Dr. Orlowski in the luncheon will answer all of your questions since he is so very knowledgeable.